I'm very much honored to present and chair this session with my colleague Howard Buchner from Boston. Howard does not need too much introduction because everybody knows him as the editor-in-chief of JAMA journal, and Howard is enriching our society with his participation for now many years, and he's going now to give his introduction and announce the first speaker. Howard, welcome.
Thank you. Thank you so much, Joseph. I'm going to borrow just a minute or so. So firstly, I want to thank you personally. Our friendship's become quite important to me, and I miss all my colleagues at ESICM. It's one of my favorite meetings of the year, and I hope we can all see each other next year in Copenhagen. I also want to just thank all of you. It's been such a difficult year around the world, and many people around the world, particularly physicians in critical care medicine, have saved hundreds and hundreds of thousands of lives. And from everyone at JAMA, I can't thank all of you enough, and I really hope you can all stay safe and healthy and visit with your families over the holidays. And lastly, I first want to congratulate Mauricio on becoming president, but more importantly, I did a live stream event with him in late February, early March. That video has been seen over 1 million times around the world. That video absolutely unequivocally galvanized the United States and many people around the world to understand what was going to happen in March, April, and May. And I think Mauricio, in the most human of terms, really explained what was occurring in Italy. And I personally want to thank him. And I think he did more to galvanize the world, to tell them, to inform us all about what was going to happen than any other single person. So Mauricio, thank you. So on to the first speaker, S. Mayatra, overview of the PUMA guidelines, project for the universal management of the airways. Sheila, take it away.
Hello, friends. Greetings from Mumbai, India. At the outset, I'd like to thank ESICM for giving me the opportunity to speak on the project for universal management of the airway. I'm sure many of you have already heard of this. Unfortunately, the publication of these guidelines has been delayed in view of the pandemic to February 2021. So I will only be presenting an overview of the PUMA guideline. I'd like to declare that I have no conflict of interest. I will be covering the following aspects of the PUMA guidelines. Now, this is the PUMA working group, and I'm very fortunate to be a member of this group. This is Dr. Karen Hagberg, who is the chair of the committee, and this is Dr. Nicholas Grimes from Australia, who is the project lead. And this is a group consisting of 14 members, 11 are anesthesiologists, 3 are intensivists, and 3 are emergency physicians. And these are all airway experts and opinion leaders in the field of airway management, and they also have experience in guideline development, and they're working together to form this unified consensus document. This is a recent review that was published in Anesthesia on difficult airway management algorithms. And it's interesting to see that over the last 20 years, and you can see here in blue, the increase in the number of difficult airway guidelines that have published. And what you see in orange is a cumulative increase in the number of guidelines. And these are of different trauma guidelines, ICU guidelines, obstetric guidelines, etc. So we have something like 38 published airway management guidelines in the last 20 years. Now, when you have a cardiac arrest, you use a common algorithm for resuscitation. There might be some regional variation, but by and large, we use the same algorithm. It's not that depending upon which part of the world you would resuscitate the patient any differently. And this is possible because organizations like the ILCO work with various other societies to form a common BLS and an ALS algorithm so that we are all on the same page. But look at the algorithms for difficult airway management. And what is seen is that there's a complete lack of a universally endorsed and accepted guideline that can be followed for different clinical settings across the globe. And there has been more and more felt the need that we need to have a common guideline that can be used universally. So essentially what PUMA's project is trying to do is that the application of the same principles of cardiac arrest training and clinical practice to airway management. So it's not like we have 100 algorithms and we are trying to make the 101st one. In fact, this is not at all a difficult airway guideline. So what we're trying to do is form a unifying document. That means look at all the existing guidelines, look at the commonalities between the guidelines and the good points and the good statements, and make a uniform kind of document which can be adapted to various situations and can be used universally across the globe. So it's not a difficult airway algorithm, but it's basically about universal airway principles that can be applied for airway management. And what's most important is this is independent of context. So it doesn't matter where you are, who the provider is, the location, the patient, what is the indication for airway management, what is the urgency of the complexity, or even the type of airway management, it can be applicable to all. Now, if you look at the rationale, I'll give you an example. I'm an intensivist and I come from background of anesthesia. And when I compare airway management in the operating room and the ICU, airway management in the ICU is just so complex. Look at the environment. Just getting to the head end of the patient to intubate the patient is just so difficult. There's so much clutter. There's a crash cart, there's ultrasound machine, ventilator, etc., all around the patient. In addition, you have varied levels of airway management skills. You have physicians, emergency medicine physicians. You don't have experts in airway management, and it depends on who you're working with in that shift. And what makes the situation most complex is these patients, in addition to a potential difficult airway, they also have what we call a physiologically difficult airway. And this is because of their critical illness. They may have an imbalance between oxygen delivery and consumption. So increased consumption due to fever, sepsis, tachypnea, etc. And in addition to that, they can have low delivery because of low cardiac output, anemia, lung disease, low FRC, etc. So this makes it even more complex. So you have a different set of guidelines depending upon where you work, and based on this, 3 different algorithms, one from the All India Difficult Airway Association, from SWAR, and also from the DAS, Difficult Airway Society, have been formulated for airway management in the intensive care unit. So you have a different set of guidelines for tracheal intubation in ICU, different for obstetrics, different for pediatrics. So just imagine if you had an adult patient who was also pregnant and a trauma victim and also critically ill, then which guideline are you going to use? Which algorithm? On the other hand, most of these guidelines are made by anesthesiologists for anesthesiologists working in different operating room settings. But we know today that airway management is done by intensivists, it's done by emergency physicians, paramedics, and also airway assistants. Now, many of them don't have their own difficult airway guidelines, and a few of them may have some guidelines. So which guideline are we going to use? Just imagine if all of them were together in the emergency department to secure the airway of a patient. Which algorithm will they use then? And in addition to this, most of these guidelines are very intubation centric, but we know today it is not intubation, it's maintaining oxygenation and ventilating the patient. And you have different devices like a face mask, supraglottic airway device, and also the endotracheal tube. And if we fail with all these 3 devices to maintain adequate ventilation, or in other words, adequate oxygenation, then we should rapidly progress to what we call the neck rescue, so that we can salvage this patient without any delay. Now, you've heard of the very famous Ellen Bromley case, and this is very highly cited. And this was a very unfortunate situation where they could not secure the airway of this patient, and she had a very tragic outcome. And what happened is the focus was largely on intubation, and they kept on and on trying to intubate. They failed to put a supraglottic airway device as a rescue, and they did not proceed to do an emergency cricothyrotomy or a neck rescue in this patient. And unfortunately, she had a very tragic outcome. And this is a classic example of lack of teamwork and lack of situational awareness. And even 15 years after this case, many of the existing airway guidelines are unable to address exactly this specific situation. So what is important is not only to have different aspects of technical skills for airway management, but also non-technical skills like cognitive efficiency and various human factor related consideration. And this consists of the what is the effect of the environment, the patient, the stress, the clinical setting on the operator, which in turn can affect his performance. And these need to be taken into consideration. Then there are many countries which don't have their own guidelines. So are we going to wait till every country has their own guidelines? And the existing airway guidelines, I think they're excellent. However, they're very context specific. Obstetrics, different for critical care, different for pediatric, etc. And what the PUMA is trying to do is to have one unifying guideline with common principles for general airway management and slight variations for specific clinical settings that can be used universally across the globe. So this avoids siloing of ideas and divergent practices. And these are universal principles, and it also forms a platform for collaboration. Now, many of these guidelines use different multiple terminologies. And, critical language is extremely important during airway management. What do we mean by critical language? Now, this is the language that we use in an emergency. For example, you cannot intubate, you cannot ventilate this patient. The patient is starting to desaturate. So you need to be very quickly able to communicate with your team that there is an emergency. So whatever term you're using, whatever language you're using has to have a sense of emergency. It should be short, it should be universally understood, it should not be abbreviated. Now, if you, the objective of PUMA was not to replace the existing critical language. We looked at the various guidelines, and we found that the most common in the literature was CAICO, cannot intubate, cannot ventilate, and leading to front of neck access, or CAICO-FONA. And though this was the commonest in the literature, most commonly performed clinically was emergency cricothyrotomy. So there was a disconnect between the language that was used in the literature and the language that's actually used in clinical practice. And only in these kind of situations did PUMA try to create different language. For example, if you look at front of neck access, FONA does not convey a sense of emergency. It's also not universally understood. Terms like, CAICO, it's not cannot intubate. It's not only intubation that helps you oxygenate, and cannot oxygenate is also very poorly understood by people. Does it mean maintaining the saturation, falling saturation, not being able to ventilate? And so the terms like CAICO and FONA have been removed from the PUMA guidelines, and FONA has been replaced by the term, and I can tell you this in advance, that we won't be using CAICO and FONA, which is the most common used in the literature, but we will be using the term neck rescue. Regarding the methods of the PUMA, and this is the working group, they come from 4 different continents, and we meet every alternate Saturday for the last 4 years via video conference. The first job we did was an extensive review of all the guidelines. We looked at commonalities in the guidelines. And then in addition, we did a literature review and tried to augment, make various statements based on this, and try to augment the existing guidelines. And this was done in the form of online surveys. We had various Likert scale ratings, also free text for people who were able to give their comments. Wherever there was disagreement, we would have video conferences to resolve them. In addition to this, we have also a 60+ member advisory group across 17 countries who help us especially address gray areas or wherever there's disagreement. Now, PUMA guidelines are not just a rehash of the existing guidelines. There are many novel content that has been introduced. In addition, the existing guidelines are silent in many areas, and PUMA has tried to address this. Regarding the format, the content, and the publication, we will be coming up with 5 documents. One is the concept and methodology paper, then one on airway evaluation, airway strategy, how you should perform airway rescue, and also communication of airway guidelines. The first one is already published in anesthesia, just recently published, and the remaining 4 documents will be published early 2021 in anesthesia, and this will also be published in intensive care and emergency medicine journals. Subsequently, we will be focusing on training programs. There'll be extensive workshops, both hands-on and online, and there'll be a lot of web-based educational resources also available. Essentially, we will be doing a lot of dissemination of the guidelines. I'd like to end by telling you that PUMA is not just another difficult airway guideline. It's essentially a unifying document. It's non-context specific, unified approach to general airway management. And PUMA has universal principles which are independent of context. And what's most important is whether having a universal algorithm to airway management improves outcome is something that we need to evaluate once the PUMA guidelines are published. On behalf of the PUMA group, I wish to thank each and every one of you for your attention and your time. Take care and be safe. Thank you.
Thanks, Sheila. I think we have time for 1 or 2 questions, and I'll start. About 6 weeks ago, we published a special communication around brain death that took years to do. And the authors came from all over the world, and there's a whole section dedicated to the concept of brain death in resource-challenged countries, which I think was a very unique aspect of the guideline. You mentioned a tiered approach with your 3 figures ending in intubation. How is the guideline going to reflect local resources? Because that is often the critical question. What may be available for you in India may be very different from other countries.
Right. Thank you very much. I think that's a very important question. And that was one of the things we tried to address right in the beginning. So what we said that the principles are going to be uniform, but there are going to be regional variations based on the needs and situation and availability. So it's kind of, I can say it's a very kind of broad guideline that can be followed anywhere. But again, depending upon the availability of the equipment, there will be slight variations. But it's a broad principle that you could apply to all different kinds of contexts, geography, settings, and clinical settings of patient management. That's what PUMA is trying to achieve.
And one other question, are you going to field test it before you send it out to the world? Sometimes you work so hard, there's 14 of you, and you end up with like kind of binoculars, very focused down. And you end up, you potentially miss something. So are there going to be outside reviewers of whatever your recommendations are, or the algorithms? It's very, very hard for journals to review guidelines for many different reasons.
Right. So we have an expert committee of 60 plus members from 17 different countries who we've been repeatedly consulting on different aspects, and they've been giving us our feedback. In addition to this, all the airway societies are involved with this guideline. So various surveys have been sent to the societies, and their members have been apprised on the activities of PUMA, and we've taken feedback from the members as well. So it's kind of, you can say, because we had a lot of time for the last 4 years, we've been working on it. It was to be published this year, but COVID has given us a bit of a setback. So we've got a lot of feedback from different quarters globally, from societies, from public, from other members of various societies. So I think we've been able to, develop and, evolve our guidelines significantly based on the feedback that we have received. So I hope to have a very exciting and good comprehensive document that hopefully will be useful for universal airway management, like we have the surviving sepsis guidelines, or we have the AHA guidelines for CPR.
Thanks, Sheila. I'm going to turn it over to Yosef to introduce the next speaker. Stay healthy and thank you.
Thank you.
Thank you very much, Sheila. Thank you very much, Sheila. The next speaker is our colleague Jung from Düsseldorf, Germany. And his presentation is on the impact of Frailty on survival in elderly intensive care patients with COVID-19, the COVID study.
Dear Chairman, dear ladies and gentlemen, dear colleagues, it's a great honor to present on behalf of the COVID investigators the results of our study, the impact of Frailty on survival in elderly intensive care patients with COVID-19, the COVID study. We would like to thank the organizers and the chairman for inviting us. Regarding the disclosures, it is important to emphasize that we did not receive any industry sponsorship. However, we received funding from the European Union and from public authorities in France and in Norway. Furthermore, the study was endorsed by the European Society of Intensive Care Medicine. As we all know, outcome predictors in critically ill elderly patients in general, and in particular with COVID-19, are not well validated. Several guidelines recommend the assessment of frailty to help in allocating and guide treatment in patients above the age of 65 with COVID-19. However, the scientific basement for that is lacking. In the clinical scenario, there are different instruments to help the assessment of frailty, and one of them is the clinical frailty scale that provides texts and pictograms from 1 to 9, and in addition to that, it provides categories that categorizes the patient as fit with a CFS from 1 to 3, as vulnerable with a CFS of 4, and as frail with a CFS from 5 to 9. In the previous VIP studies, and VIP stands for very old intensive care patients, we were able to describe this relationship between frailty and mortality, and we were able to show that with increasing CFS, mortality increases in a large cohort of several thousand European intensive care unit patients. This association was furthermore confirmed in the VIP2 study, and in this study we were able to show that frailty as assessed by CFS adds an additional dimension with regards to outcome prediction to disease severity and age. Therefore, we created the COVID study that investigates this relationship in COVID-19 patients. We used the VIP network and defined the inclusion criteria as follows after ICU admission: age above the age of 69 and proven COVID-19 disease. The study was organized in conjunction with national coordinators that coordinated the study on the country level. We programmed the dedicated website and organized data collection via an electronic CRF that was based at the University of Aarhus, Denmark. 1,590 patients were registered. However, we excluded patients included after May 26 in order to reflect the first wave of the pandemic in the participating countries. And we furthermore excluded patients with a missing CFS from the analysis to allow a full statistical approach. This resulted in 1,346 remaining patients that were collected on 138 ICUs across 28 different countries. These patients were 28% female, had a median age of 75, a median SOFA score of 6, and were characterized by frequent occurring comorbidities. 21% of the patients were frail, and these frail patients were even more frequent female, were older, had a higher SOFA score, and were even more frequent characterized by these comorbidities. The primary endpoint was survival after 30 days, and this was met for 59% of the patients. However, illustrating patients according to their fit, vulnerable, or frail status, there was a significant difference at the primary endpoint and also a significant difference at the secondary endpoint after 90 days, which means that frailty status is of prognostic relevance. By illustrating the patients regarding their frailty status in conjunction with their age above or below their median, it is important to see that age had prognostic differing implications for patients that were fit. However, patients that were frail, there was no difference regarding their age. As already indicated, 59% were living after 30 days, and as illustrated in the Kaplan-Meier curve, this was different between fit, vulnerable, and frail patients that resulted in a survival of only 41% of the patients that were frail. In addition to that, we analyzed the occurrence of treatment limitations, and it is important to see that patients with frailty received treatment limitations more often compared to patients that were fit. And, for example, patients with frailty received less likely mechanical ventilation during their treatment. In order to study this association in more detail, we created 3 different time-dependent Cox models to study the association of frailty with outcome. And as already indicated with the Kaplan-Meier curve, the unadjusted hazard ratio was increased for patients that were frail in order to be not alive during their treatment. And this model was furthermore in the second model investigated with controlling this association for age, sex, comorbidities, SOFA score, the body mass index, and the respiratory situation. And in the third model, the association even remained to be present when to this second model, management strategies were added. And management strategies summarized renal replacement therapy, cardiocirculatory support, respiratory support, withholding and withdrawal of therapy, which means that even when patients with frailty received more frequent therapy limitations, after controlling in the model for these circumstances, the association of frailty with outcome remained statistically significant. Therefore, I would like to conclude, frailty provides relevant prognostic information in elderly COVID-19 patients, in addition to age and comorbidities, and can therefore be used to guide therapy. CFS is feasible to be obtained at admission as tool to assess frailty, even in a surge such as the current pandemic. With this, I would like to thank you on behalf of the COVID study investigator for your attention, and especially we would like to thank all centers and local investigators to make this study possible, even in the situation such as the current pandemic. Thank you very much.
Thank you very, very much, Christian, for this extremely important study. I mean, we were following the previous 2 studies. They were giving excellent information. This one is even more important, especially in the situation with COVID-19 that we are facing the last year, because we know that there are some factors affecting the prognosis of these patients. And this study enlightens us a little bit more on that aspect. One question coming from the audience is the criteria was 80 years in the previous studies. Why in this one is 70 years? Can you elaborate on that?
Yes, thank you. Of course, we discussed that while we were planning the study within some days only. So we started already recruitment mid of March. And of course, our core group was studying patients above the age of 80. But while witnessing what was going on in most countries was that we expected that we might not catch enough patients to get a meaningful message at the end. Therefore, we lowered the threshold to age of 70. And in fact, using frailty scale is recommended for patients above the age of 65. So we are in a safe, validated area, but we were the task was to create meaningful message for elderly patients.
Christian, I have a question there, because I think if I remember correctly, you have indicated in your one of your last slides that frailty could be used also to determine beforehand the patients who will be benefiting or not benefiting from the ICU. But I think this is more for the group, right? It's not for individual basis that we can scan patients beforehand.
Well, with this study, we would not like to claim that we can say anything about the triage before ICU admission, because we only included ICU patients. Looking into the literature, it might be rational to incorporate frailty also in a decision-making and in a whole bundle of information. But with this study, we only investigated ICU patients. I mean, only, which is important enough to our we are convinced by that.
Okay, I would like to thank you once again for this excellent study, because I think our intensive care society and people needs these sort of studies, especially in these difficult times. In such a short time, designed and performed. I congratulate you again and give the word to Howard again for the next.
Thanks, Christian. So we'll go on to the third presentation. It's entitled Clinical Characteristics and Day 90 Outcomes of 4,244 Critically Ill Adults with COVID-19, a prospective cohort study by M. Schmidt, Paris, France. Matthew.
Good afternoon, everyone. Thanks to ICM for letting me the opportunity to present you the COVID-19 ICU cohort study that was just released in intensive care medicine. So here are my disclosures. So the objective of this large cohort was to report detailed information of critically ill COVID-19 patients, to report their baseline characteristics, their ventilatory management, their RDS severity, and 90 days outcome. This study is a multi-center prospective cohort study that was conducted in 149 ICU in 3 countries, France, Switzerland, and Belgium. Inclusion criteria were very simple. Adult patient admitted to in the ICU between February 25 and May 4, so roughly 2 months during the first wave. And this patient should have a laboratory confirmed severe acute respiratory syndrome due to coronavirus SARS-CoV-2. So here are the flow charts. So we obtained 4,244 patients with 90-day follow-up. And if we look first at the characteristics of this patient, you see that these patients were quite young, with the median age at 63 years old, mainly men. 75% of the population was male. These patients were in overweight, with a BMI, median BMI at 28, with 41% of this population considered as obese. The SAPS-2 was 37 in medium, and the SOFA score at ICU admission was 5. 48% of them had a treated hypertension, 28% had no diabetes. The clinical frailty scale was quite low, at 2 in medium, and they were admitted in ICU after 9 days after the first symptoms. So if we look at the ventilatory characteristic and the ventilatory management during the first 24 hours, you see that 63% of them were ventilated at day 1. The PF ratio, the median PF ratio for all of the patients was 154. They were ventilated with low tidal volume, high PEEP, and a resulting plateau pressure at 24 centimeter water in medium. With a driving pressure at 13, the static compliance was distributed as 1/3 of the population with static compliance less than 30, 1/3 between 30 and 40, and 1/3 of the population with static compliance over some 30. So first of all, you see that the bacterial co-infection was quite low. Only 5% of this patient has a bacterial co-infection, and only the lung were impaired during day 1 with a low hemodynamic and renal SOFA score. And you see that this patient has, for most of them, has a profound lymphopenia with high digimer level. So if we look at the RDS severity, you see that at day 1, for 2,233 patients ventilated at day 1, 22% has a mild ARDS, 54%, so the largest proportion has moderate ARDS, and 22% has severe ARDS. When we look at the ventilatory failures on day 1 of this patient with IRDS based on the Berlin definition. The plateau pressure was 24 in medium and increased with the severity of IRDS. It was the same for the driving pressure, which was at 13 centimeter water, which increased with IRDS severity. Same for the compliance, which decreased also with the severity of IRDS. The management of this patient ventilated at day 1 in ICU. So a large proportion of them receive prone positioning, 70% receive prone positioning with a median number of sessions at 3, and a large proportion of them receive, 88% receive continuous neuromuscular blockade, and where it's the ECMO was used for 15% of the severe IRDS population. About the complication, you see that thromboembolic complication was important. 17% of the population has thromboembolic complication, with 9% with proved pulmonary embolism, and 28% got a renal replacement therapy. When we look at the outcome and we compare it to the lung safe study, you see that the duration of invasive ventilation was at 13, in median at 13 days for the surviving patient at day 90, and it was much higher compared to the lung safe study, where the median duration of invasive ventilation for the surviving patient was only 8 days. It was the same for the ICU length of stay. When you compare the length of stay in ICU for the surviving patient compared to the lung safe study, you see that there is roughly 10 days difference for the COVID-19 patients. So they spent more than 10 days more in ICU. And despite a longer ICU stay and longer duration of mechanical ventilation, you see that ICU mortality was quite similar at 35% in that population ventilated at day 1. When we look at the hospital mortality, you see that the hospital mortality was very comparable to the lung safe study, even if it increased with the severity of IRDS. And when you look at the 28 mortality in both cohort lung safe study and COVID ICU study, you see that the day 28 mortality was roughly similar. And when you compare the day 90 mortality with hospital mortality in the lung safe study, you see that the mortality was very similar in the different classes of IRDS, going from 30% for mild IRDS to more than 50% for severe IRDS. So if we look at the overall outcomes, we observe a 31% mortality at day 28 mortality for the whole population, and 37% mortality at day 90. When we look at the factor associated with 90-day mortality, we find that age was a strong factor associated with 90-day mortality, with a large difference in worse prognosis for those patients older than 74 years old. Immunocompromise was an associated predictive factor of 90-day mortality. The BMI extreme, especially the extreme obesity, was associated with 90-day mortality. Diabetes was also associated. We find a relationship between the times between the first symptom and ICU admission. The longer this delay, the better the prognosis, and it was already demonstrated in previous study published in intensive care as well. Other extrapulmonary impairment was associated with worse outcome, and the PF ratio at baseline was also associated with a worse outcome at day 90. What about the mortality over the study period? So you see that the oxygenation modality changed a little bit. If you split these 2 months into a 2 weeks period, you see that the high flow oxygen used increased during these 2 months, with less patient intubated at day 1 and roughly less patient intubated. And at the end, you see that the day 90 mortality decreased over the study period from 42% during the first 2 weeks to 25% in the last 2 weeks of the study. So at the conclusion, the overall 90-day mortality was 31% and decreased over time during that period. The 90-day mortality increased with the severity of ARDS from 30% in mild to 50% in severe ARDS. We observed very long duration of mechanical ventilation and ICU stay, and all these factors largely contribute to the swamping of ICU capacity. And now we expect long-term follow-up to perfectly describe what is the prognosis of these patients. So I would like to thank all the French, Belgium, and Switzerland center who have participated to this very large cohort. Thank you very much.
Thanks, Matthew. Comprehensive, excellent report. And I want to dig down a little deeper into your very first bullet point in the conclusion, which mortality has declined. It's declined a little less for people who were ventilated over the 8 months. There's a fair amount of data. But why do you think we're better at taking care of these patients? What's been the key at getting better? What's the message as we go forward? Because sadly, at least in the United States, we have 100,000 people who are in the hospital, many in the ICU. So how have we improved? What's been the key to improvement?
I think there are many factors, and the first of it's better knowledge of the disease. The second one is probably less reluctance from the caregiver to use non-invasive oxygenation modalities, and this is what we show in our study, that the use of high-flow oxygen was much more frequent at the end of the study period. And also, this study was performed before the result of the recovery trial, so not all patients received systematic corticosteroids. And I think at least the 3 points could help to improve the outcome of this patient at the end.
There's a couple questions. I'll read you one. Why were some patients with mild ARDS put on ECMO? Do you have any sense of that? I think it showed about 8 or 10% of people with mild ARDS on ECMO.
Yeah, because the classification is the ARDS classification at day one of intubation. So the patient could be a mild ARDS at day 1 and move to severe ARDS at day 5 or day 6 or later on. So this is the explanation.
And another question, were pre-morbid conditions, comorbidities, associated with 90-day outcome? I think you showed that obesity was. Were there other comorbid conditions that were associated with 90-day mortality?
Yes, so it's mainly extreme obesity. So I mean a BMI over 35. And what we showed is also the strong impact of diabetes. Which was highly correlated to 90-day mortality.
And last question, Matthew, when you're caring for these patients, obviously this has ushered in a whole concept of proning, which I think was always around, but has become much more important. In the US, there's literally proning teams that go from bed to bed. Do you think that's a key component to people who are critically ill in an attempt to try to avoid intubation, mechanical ventilation?
So actually, the benefit of proning before intubation, it's still a large debate. What is sure is that as soon as the patient is intubated, we should prone him to try to improve it, to try to reduce the duration of invasive mechanical ventilation.
Right. A wonderful collection of data. Thanks so much, Matthew, and stay healthy and taking care of patients.
Thank you.
I'll turn it over to Yosef.
Thank you. The next speaker is colleague Rood from Nijmegen, the Netherlands, and the study he will present now is the Underpin ICU study. Ladies and gentlemen, there is a small technical problem with this presentation. We will come back to this soon. In the meantime, I would like to announce the next presentation, blows from Jena, Germany, and the floor is open for our colleague Blows on the diagnostics of invasive Candida infection versus culture-based diagnosis.
Hello, my name is Frank Blows. I'm presenting to you the Candida trial, where I had the honor to be the principal investigator. The study was sponsored by a grant from the German government, and the Associates of Cape Cod sponsored the BDG glucan assay with an unrestricted grant. I received a honorarium for an expert advisory board meeting by Baxter and lecture honoraria from Biosen. Now, mortality of invasive Candida infection is quite high. It's about 40%, and treatment delays further reduce survival. As you know, microbiological proof of Candida infection takes time, and therefore it is quite difficult to identify those patients who may benefit from an early antifungal therapy. So maybe a biomarker approach may be the way out of this dilemma. And in fact, 1,3-beta-D-glucan, or BDG for short, is present in the bloodstream of patients with invasive Candida infection, and therefore BDG has been advocated as an early diagnostic test. However, guidelines are reluctant to recommend BDG guidance. There is disputed whether BDG is accurate enough, especially in the ICU environment, and there is a lack of randomized trials about this issue. So therefore, we did this trial with the hypothesis that BDG guidance results in early antifungal therapies in patients with high risk of invasive Candida infection and reduces mortality. The study protocol was published in advance in the Trials magazine in 2018. We included adult patients with severe sepsis or septic shock and an onset of sepsis of maximally 12 hours. However, we had to increase this time window to 24 hours because of insufficient recruitment. The patients also had to have an increased risk for Candida infection, which was defined as one of the following: either total parenteral nutrition, recent abdominal surgery, pre-existing antimicrobial therapy, independent from the present sepsis episode, or pre-existing hemodialysis. We excluded patients who were already treated for invasive fungal infection or where systemic antifungal therapy was imminent. We excluded patients on immunoglobulins or receiving cardiopulmonary bypass because these interventions are known to increase BDG levels independent of invasive Candida infection. After recruitment, the patients were randomized into groups, either a control group where antifungal therapy was decided at the discretion of the treating physician, or a BDG group where antifungals were starting depending on the beta-glucan result. The trigger was 80 picogram per milliliter. In fact, we took blood samples for BDG after randomization, and the second one 24 hours later, together with concomitant blood cultures. The control group, we also took those BDG samples, but the BDG results were not forwarded to the treating physicians. We also took surveillance cultures for Candida colonization on day 1, day 7, and day 14. Primary outcome was 20-day all-cause mortality. This was a multi-center trial performed in 18 hospitals in Germany in tight collaboration with the SEPNET study group. Now, the handling of the BDG kit is rather complex, so we decided to have a central lab at the Department of Microbiology in Erlangen, who has quite good experience with this kind of measurement. However, this meant that we had to transport each sample with a carrier service from the study site to the central lab. The study was done from September 2016 until September 2019, and we recruited 342 patients. These are the demographic data, and what you can see is that we have quite good distribution, equal distribution of the parameters between the groups. They were of similar age. We had similar comorbidities or similar scores of severity, and an example, same rate of mechanical ventilation at baseline. These were the risk factors for invasive Candida infection at enrollment. Blue is always the BDG group, and red is always the control group. You can see as well an equal distribution of the risk factors, and most importantly, the most frequent risk factor was abdominal surgery, followed by pre-existing antimicrobial therapy. On this slide, you see time to antifungal therapy, so the fraction of patients not being on antifungal therapy actually. And as you can see, the trial intervention resulted in a nice separation of the groups. You have in the control group, the median time to antifungal therapy was about 4 days, having at the end about 30% of the patients being on antifungals. However, in the beta-glucan guided group, time to antifungal therapy was about 1 day, having about almost 70% of patients being on antifungal therapy. However, this did not result in a reduction in 28 mortality rate. There was no difference between the groups. We had an overall mortality rate of 33%. And this is something which needs to be discussed, because in the sample size calculation, we had predicted a much higher mortality rate for the control group, in fact, about 50%, because of the severity of this severity of illness of this certain cohort. If you look at other secondary outcomes, we also had no difference in hospital mortality or in ICU mortality, as well as in the organ failure-free days, such as vasopressor-free days, ventilator-free days, or renal replacement therapy-free days. As shown on the previous graph, there were BDG group patients received the antifungals much earlier. You have already seen this. But interestingly, the antifungal-free survival at day 28 was less frequent in the BDG group. And since there was no difference in the overall mortality, this actually means that we had more patients on antifungals at day 28 in the BDG group than in the control group. This resulted in higher costs of antifungal therapy in the BDG group. However, this did not reach statistical significance. Candida decolonization with 0.2 was surprisingly low in this cohort, and it also did not increase over time, as you might expect in such a high-risk cohort. So why was Candida a negative trial? Obviously, BDG did not select patients at risk. This may be a problem of specificity. An example, several parameters like albumin therapy may interfere with the results. And we had a high share of patients after abdominal surgery, a condition which also is known to increase BDG levels. The study had some weaknesses. We had a rather low rate of invasive Candida infection. We expected a rate of 28%. This may be a reason why we had a low mortality rate. And compliance to the algorithm was moderate with about 67%. So in conclusion, 1.3 beta-D-glucan guidance resulted in an early antifungal therapy and more antifungal therapy, but did not affect outcome in this patient cohort. Thank you very much for your attention.
Thank you very much, Frank, for this very interesting study. And I was preparing a question for you. I saw that there's a similar question coming excuse me, from Maria Juliana Zapatero. Actually used 1,3 beta-D-glucan for an early diagnostic test, but you had some clear exclusion criteria. And the exclusion criteria were here, for example, were for immunocompromised patients or end-stage cirrhosis. Well, if you are really wanting to show some effect on mortality, perhaps these patients were not very bad to include there because they are more prone to have these infections, and early diagnosis might mean there maybe a little bit more. And I'm not wanting to indicate that patients with abdominal surgery or on parenteral nutrition are better patients, but still I thought, and probably Maria Juliana has also thought, that we need a little bit of explanation of your consideration to exclude these patients.
Yeah, I think this is a very important point. Patients on liver cirrhosis and sepsis have a very high mortality, like up to 80%. So the sample size calculation and all the predictions that we did for study planning was taken from studies that excluded those patients. And therefore, we decided at the end that this very high-risk population should not be included into this trial.
There is another question from Joao Fortunato. He's asking how do you use BDG in patients on ongoing continuous renal replacement therapy or intermittent hemodialysis? So
hemodialysis was not an exclusion criteria. So those patients were in the trial, and although it has been suggested that patients on hemodialysis may have increased PDG values because of the cartridges, there are other studies that showed other results. So we did not decide to exclude these patients. Patients on hemodialysis were treated in this trial as any other patient too. So they were, yeah.
Okay, considering the time, I think we should go on. Thank you very, very much for this interesting study. And I will give the word back to Howard for the next presentation.
Thanks, Joseph. Thanks, Frank. So the next study, we're going to go backwards to catch up, is the Underpin ICU study by P. Rod from the Netherlands.
Hello, my name is Paul Rood and I'm a former ICU nurse currently working as senior researcher. During my PhD, I have executed the Underpin ICU study, a multi-center step-wedge cluster randomized controlled trial focused on the effect of non-pharmacological interventions on delirium and other relevant outcomes. The Underpin ICU study was funded by the Dutch government. I have no other disclosures. Delirium is an acute disturbance in attention, awareness, and cognition, which is caused by physical disbalance and not better explained by other factors such as coma. The occurrence of delirium is associated with impaired short and long-term outcomes, such as the extended need for mechanical ventilation, prolonged length of stay in the ICU and the hospital, and increased cognitive impairment up to 12 months after ICU discharge. Delirium is a complex syndrome with a multifactorial etiology. As currently real-time assessment of the actual pathways is not possible, delirium guidelines provide general recommendations and individual tailoring is left to caregivers. There is strong evidence supporting multi-component intervention to prevent delirium in non-critically ill hospitalized patients. Studies going back as far as 1999 have found that management of risk factors for delirium resulted in a 40% reduction of the development of delirium compared to usual care. Two recent meta-analyses confirmed these results and have estimated them to be cost-effective by reducing length of stay and prevention of falls. In critically ill patients, delirium develops in about a third of patients. Delirium is not a standalone problem, but interacts with other frequent ICU problems, such as pain, agitation, and sleep. Current guidelines therefore state that prevention and treatment of delirium in critically ill patients states that a coordinated approach combining these aspects of ICU care is required. It is important to realize that as critically ill patients differ from non-critically ill patients in several ways, the question remains whether these results may be found in delirium research outside of the ICU are directly generalizable to the critically ill patients. Currently published ICU trials are mainly relatively small, non-randomized and single-center conducted, which make the certainty of these evidence for these interventions low. Therefore, the aim of the present study was to determine the effect of a multi-component program of non-pharmacological nursing intervention aimed at modifiable risk factors on the number of delirium-free and coma-free days alive and other relevant ICU outcomes for critically ill patients. To do so, a step-wedge cluster randomized controlled trial was designed, including 10 ICUs as clusters. Recruitment of patients took place between December 2016 and May 2019. We included adult critically ill surgical, medical, or trauma patients at high risk of developing delirium, and at all centers started as controls. Every second month, the program was implemented in a randomly assigned center. Primary outcome was the number of delirium-free and coma-free days alive in 28 days after ICU admission, and secondary outcomes included delirium incidence, delirium duration, mortality, and other relevant ICU outcomes. The intervention of the underpin ICU program were derived from previous literature of successful programs in non-critically ill and critically ill patients. The domains covered were visual and hearing impairment, sleep deprivation, cognitive impairment, and immobility. The feasibility was interprofessionally assessed in a national executed Delphi round and a pilot study before onset of the present study. Nurses were instructed to see the underpin ICU program as a toolbox, which they could, based on their clinical expertise and patient values, could individually tailor to patients' needs while covering the domains as much as possible. To enhance active recognition, a summary poster was developed containing materials and domains, and to enhance clarity and reproducibility, pictograms were added in the template materials. To involve families, also an information poster was made, which included instruction for supported communication. For patients, a standardized whiteboard was made available in all rooms, which enabled providing daily care structure to patients. And finally, families were asked to fill in a Get to Know Me poster, which enabled all visitors to know the preferred manner of addressing the patient, daily living activities, and additional interests as well as impairments. We now proceed to the results. Of over 24,000 patients admitted to one of the participating ICUs, the majority was excluded because they had an expected stay of less than 24 hours or had a low risk of developing delirium. A total of 1,749 patients were included, 924 in the intervention period and 825 in the control period. As may be seen in the table, the groups were very similar at baseline, with a mean age of 71 years, 60% men, and an Apache 4 of 82, the majority of patients were urgently admitted for medical reasons and were respiratory insufficient. Half of them had audio-visual problems pre-ICU admission. Several process measures were monitored. First, the participating observations were performed. Furthermore, nurses daily registered delirium, sleep, and workload scores. Light and sound levels were continuously monitored throughout the study, and cognitive training exercises were applied and monitored real-time through an app. As may be seen in the table, the time spent on daily on the underpin ICU interventions was median 38 minutes in the intervention period and 32 in the control period. The time spent on improving cognitive function increased, and the light and noise levels significantly changed during the implementation. Sedation levels, quality of sleep, and objective workload did not significantly change following implementation. Then the primary outcome. The median number of delirium and coma-free days alive was 23 in the intervention period and 23 days in the control period, and thus did not change. In this table, all outcomes are presented. Also, in all secondary outcomes, no differences were found. For instance, the delirium incidence and duration were similar. So to conclude, in adult ICU patients, the use of multi-component nursing interventions did not improve the number of delirium and coma-free days alive in 28 days. These findings do not support the application of such a program in the context of relatively low delirium incidence and duration. However, possibly, the intervention may be effective in other contexts of lower baseline application and higher delirium occurrence and duration, and or when combined with other interventions, such as the A2F bundle and minimizing the use of medications such as benzodiazepines. Gratefully acknowledge all whom supported our trial. Also our research colleagues from the ICU of the Radboud University Medical Center. And lastly, I want to thank you for your attention. Thank you.
Thanks, Paul. We've been at this for almost 2 decades, trying to reduce delirium in the ICU. JAMA's published quite a few studies in this area. So a couple questions, one of which, has come from one of the people who's watching the presentation. What was the risk of developing delirium? How did you measure? Were people at high risk? That's the first question. So did you not focus on people who were at highest risk? And then secondly, is it one size doesn't fit all, that some people need more activity, others need more cognitive training? As I said, this has been a 2-decade-long search to reduce delirium unsuccessfully. And the question is, are the interventions off, or are they not tailored specifically enough? What's your feeling from having conducted the study in your own clinical experience? So how did you assess delirium? Were patients at high enough risk for it? And do we have to just take a different approach?
Thank you for your questions. At first, the risk of delirium was assessed using the e-pre-deliric tool, which was developed prior to this in the execution of this study. And we aim to include the 10% highest at-risk patients for delirium. So that's how we did that. Secondly, I really agree that it's important to personalize delirium treatment, and that's why we instructed nurses to individualize the program to individual needs based on their clinical expertise. However, probably it's not just alone non-pharmacological interventions, and possibly patients could benefit from more specific individualization of targeting strategies, and also combining non-pharmacological and pharmacological interventions together, such as in the A2F bundle, which is currently also recommended by the SACM.
Quite a few other questions have come in, so I'd like to go through them. So if you can try to keep your responses brief if possible. Did you measure pharmacologic interventions between groups?
Yes, we did, and we report them in our study also, but they were similar.
They were similar. And what were the common drugs that people used?
Mostly haloperidol for delirium prevention, and for sedation, propofol, and in lower amounts also midazolam. But we try to reduce the use of benzodiazepines as much as possible.
What type of cognitive training was used in these patients? I think I'm personally interested in that, so if you could tell me, I'd be very appreciative.
Yeah, of course. We also already published our pilot study about that. We made a package of cognitive training interventions, which included simple tasks for patients to do. So remembering the days of the week and the months of the year, and that sort of interventions, which were derived from the neural rehabilitation medicine, actually.
Okay. And one more question. Kim Sale says, or were you disappointed that the difference between groups and extra attention was 38 versus 32 minutes? Would you have expected it to be more? So was part of the struggle that the nurses in the so-called control group figured out that they should do this regardless of whether that was the intervention period or not the intervention period?
Yeah, we did prior to this study, we estimated the amount of time and energy spent on delirium, and that was then really relatively low. But during the execution of the study, we saw that there's was already quite a significant amount of time spent, actually. So therefore, possibly we could not achieve a difference. However, also in our control periods, the delirium incidence, the duration were already relatively low compared to other publications that were recently submitted. So we're not sure what the exact cause is for the lack of result.
Last question, Paul. What role do you think families have? I mean, I think the focus on nurses is great, but they're incredibly busy in the intensive care unit. Is there a way of trying to engage families to help? They visit regularly. They know the patient. Is there a way of using families that you think could be more effective?
Yeah, we do think so, that family incorporation is really effective. That's also published in recent publications that were currently done. But there might be great potential in it, but it needs to be further studied to confirm our feelings that incorporating families in the care for patients will benefit them and also possibly the next of kin themselves.
Well, I know the results are disappointing, but it's a remarkable study. Congratulations, Paul. It's a lot of work.
Well,
Thank you very much.
Well, the next speaker is a longtime associate and friend of mine, Marcus Schulz from Amsterdam, the Netherlands, and he has spent his last 20 years or so on pressures and volumes on mechanical ventilation. And his title now is The Effect of Lower versus Higher Positive and Expiratory Pressure Strategy on Ventilator-Free Days in Intensive Care Unit Patients Without ARDS, a randomized clinical trial. Marcus, please.
Chairman, ladies and gentlemen, thank you very much for your interest in this presentation, during which I will show you the results of the RELAX trial, a study into the effects of a lower versus higher PEEP strategy on ventilator-free days and the life in ICU patients without ARDS. The findings of this study will be presented in a JAMA publication that is released simultaneously with this presentation, and here I would like to thank the editor-in-chief and the section editor for their help in preparing this document. I have no real conflicts of interest with regard to the content of this presentation. The presentation in JAMA comes with a very nice infographic summarizing what we did over the last 3 years. So we performed a randomized clinical trial in 8 ICUs in the Netherlands, randomizing 980 patients to a lower PEEP strategy or a higher PEEP strategy, and we compared the primary outcome of the number of ventilator-free days by study day 28 using a non-inferiority design. The findings are found on the right of this slide, showing us that there is non-inferiority of a lower PEEP strategy versus a higher PEEP strategy in these patients, meaning that a lower PEEP strategy is as good as a higher PEEP strategy. These are the investigators involved in this study, a large group of investigators that worked very hard over the last 3 years, and a special thank you to Annegeke Algera and Frederik Paulus, who did most of the work. So I will discuss now the background of this study, the questions that we had, the methods that we used, and finally come with the results and conclusions. In patients with ARDS, several randomized clinical trials over the last 2 decades showed no benefit of a higher PEEP strategy when compared to a lower PEEP strategy. One IPD meta-analysis suggested benefit, but only in patients with moderate to severe ARDS, and actually harm was suggested from a higher PEEP strategy in patients with mild ARDS, as in these patients it seemed to delay extubation. Meanwhile, there's increasing interest in how patients without ARDS are being ventilated and the role of PEEP in these patients. This was an observational study in which patients at a high risk of ARDS, but not having ARDS, were compared to patients with a low risk or no risk of ARDS, nicely showing that a higher PEEP level is increasingly being used when these data are compared with previous studies. 7 to 8 centimeters of water is standard of care in these patients in many ICUs in many countries. Now, is this a good thing or is it a bad thing? Is there benefit or harm of use of a higher PEEP strategy in these patients? Benefit could exist, for instance, if there is an improved aeration, leading to a better oxygenation. And some studies suggest that there may be less ARDS and maybe less ventilator-associated pneumonia with the use of a higher PEEP. Animal studies, however, suggest that there is a risk of overdistension, and maybe there is an increase in the worsening or inducing of new lung injuries. This is all based on animal studies. We also know that the use of a higher PEEP is associated with impaired hemodynamics or could impair the hemodynamics. And it may, in theory, the extubation, as we clinicians usually extubate patients at a lower level of PEEP. So we had the following question. In ICU patients who received invasive ventilation for reasons other than ARDS, is a ventilation strategy using a lower PEEP non-inferior to a strategy using a higher PEEP with respect to the number of ventilator-free days in the life at day 28? Why did we use a non-inferiority design? Non-inferiority designs are increasingly being used in drug studies in which you ask the question, is a lower dose, in this case a lower level of PEEP, as good as a higher dose, in this case a higher level of PEEP? And we use the composite endpoint of ventilator-free days at day 28 because it combines mortality with duration of mechanical ventilation. So this was a randomized controlled trial performed in 8 centers in the Netherlands with a pre-published protocol and a pre-published statistical analysis plan. It was approved by the local institutional review boards, and we used deferred informed consent. We had a DSMB for oversight, and we performed no interim analysis. Patients were eligible if they were intubated shortly before or in the ICU, and were expected not to be extubated within the next 24 hours. We also wanted only to have patients that started with mechanical ventilation within 1 hour of randomization in the ICU. And we had other exclusion criteria like ARDS or COPD, but would like to refer to the trials and JAMA paper for the additional exclusion criteria. We used a 1-to-1 ratio randomization performed by local investigators using a web-based program, and we had random block sizes of 2 to 8 patients per center. Mechanical ventilation in the two groups was merely the same. The only difference were the PEEP FiO2 titrations. In the lower PEEP group, PEEP started at 5 centimeters of water, which was then down titrated in steps of 1 centimeter of water until the oxygenation was worsening, meaning it could not be sufficient with an increase in FiO2 with a maximum of 60%. In the higher PEEP group, ventilation started with 8 centimeters of water and stayed at 8 centimeters of water PEEP until extubation. Standard of care was the same in all hospitals, and here I also would like to refer to the trials and the JAMA paper on information regarding that. The primary and secondary outcomes are depicted on this slide. So we had the ventilator-free days in the life at day 28 is the primary endpoint, ICU and hospital lengths of stay and 28-day and 90-day mortality, but also the occurrence of pulmonary events like ARDS or ventilator-associated pneumonia. And we collected data regarding the use of rescue therapies for hypoxemia or atelectasis like prone positioning, higher ventilation pressures to open up lung tissue that may have been collapsed. And we also collected days with vasopressors and days with sedation, but I will not discuss them here in this presentation. We calculated we needed 490 patients per group to show or demonstrate the non-inferiority of a lower PEEP strategy. We used an intention to treat analysis, and we used Kaplan-Meier curves to show several of the outcomes. The randomization resulted in two well-balanced group of patients. 80% of them were medical, and 30% were intubated because of acute respiratory failure. The two ventilation strategies resulted in a contrast with regard to the PEEP level, as shown here on top, and with regard to the FiO2 level, showed here on the bottom of the slide. This is regarding the primary endpoint. First, I would like you to refer to the non-inferiority margin, which is shown here in blue. If the line of the 95% confidence interval for the mean ratio difference does not cross the blue line, it means that the intervention, in this case a lower PEEP strategy, is non-inferior with comparison to the higher PEEP group. And as you can see, this is not happening, bringing us to the conclusion that a lower PEEP strategy is not worse than a higher PEEP strategy with regard to the primary endpoint. We found similar findings for the subgroups that were predefined. The other endpoints are shown here, like duration until extubation, hospital and ICU lengths of stay, and mortality. And in all these endpoints, there were no differences between the two groups. Patients with a higher PEEP strategy were having a better oxygenation and less hypoxemic events and less rescue therapies, but these differences were not statistically significant. So we conclude that a lower PEEP strategy is non-inferior with respect to the number of ventilator-free days and alive at day 28 as compared to a higher PEEP strategy. This study had several strengths. We minimized bias. We performed a study in academic and non-academic centers, meaning that the findings are generalizable, and we used a short randomization period of 1 hour to prevent against the carryover effect. The non-blinded design and the large heterogeneity in the two groups is a weakness, but we did not find any difference in the subgroup analysis. So in conclusion, a lower PEEP strategy is as good as a higher PEEP strategy, and this adds to our knowledge about the influence or the effects of PEEP in patients without ARDS. Thank you very much.
Thank you. Thank you very much, Marcus, for this very nice and interesting study. And I have a couple of issues to discuss with you, actually. If we look at 50 years of history of PEEP use with ARDS patients, we have a very clear-cut reasons to do that, you know, with all the compression atelectasis and all the pathophysiology and etc. While if the patients do not have ARDS, that does not, of course, necessarily mean that the lungs are completely normal. But I'm very much interested to know from you, what was the idea, the pathophysiological hypothesis with patients without ARDS that high PEEP would be better? Or why did we have the necessity of showing that low PEEP is also not inferior? What was the pathophysiological hypothesis behind the design of this study?
Thank you for this question, Joseph, and thank you for your kind words. I think it's all a matter of balance between overdistension that could be caused by a higher level of PEEP and atelectasis that could be caused by a lower level of PEEP. And this balance may be more in favor of using higher PEEP in patients with ARDS or injured lungs as compared to patients with non-injured lungs, as we were testing in this study. And yes, we have a long history of what is the best PEEP level. You were my trainer 20 years ago, and you learned me actually that 5 centimeters of PEEP was good, but only because we have 5 fingers, and there is not a good rationale for using 5 or something else like that. And this is exactly what I took into this study. So thank you for your inspiration, Joseph, 20 years ago.
Another question comes from the floor, with congratulations. The question is, can you explain the use of 8-centimeter water as high PEEP? Many intensivists would not consider this to be the case.
Good question again, and I would like to thank the one in the audience who's asking this. We had the same discussion with the editors of the journal and with the reviewers. What is high and what is higher and what is low and what is lower? We deliberately chose here for naming 8 centimeters high or higher. And we chose that level because we found in the PROVENT study that this is increasingly being used, especially in the Netherlands, where we did a Dutch study or another study just only focusing on Dutch centers, showing that it was 8. Now, you could ask yourself the question if 8 is high enough. I don't know, actually.
Well, I mean, the next question is maybe about that, because the person who asked the question says, what about obese patients? I think you will be saying that the extension of your answer would be there.
Well, actually, you can think of a new study looking only or focusing on obese patients, but I would like to refer to several studies that have been performed now in the operating room, like the PROBI study as an extent of the PROVILO study, that was especially looking at the levels or the effect of higher levos of PEEP in obese patients, finding no benefit of a higher PEEP level when patients are obese. So at the working floor, at the bedside, I am against this arguing that we should use a higher level of PEEP in more obese patients.
Okay, Howard, as the editor-in-chief of this paper, do you have any comments to add?
Well, I think, firstly, it's a remarkably handsome study, multi-site, academic, non-academic, and the intervention really differentiated between the two groups, which is one of always the challenges, particularly in mechanical ventilation studies. Did you get the effect you were looking at? I think we internally, and I think people know that our section editor for more than a decade has been Derek Angus, although he was just promoted to becoming senior editor, and Chris Seymour is now the section editor. So feel free to contact either of them. The real question was the non-inferiority margin, which comes up all the time in non-inferiority studies. Who decided that 10% was sufficient? That is always a question in non-inferiority studies. And then secondly, and Mark has already commented on it, as did all three of the reviewers, all well-known respiratory physiologists, was the 8 centimeters of PEEP. Was that the appropriate target? And I think the good news for Marcus is it allows him to do more studies, because I think that remains a question. And if you look at the tote board, as is often the case with mechanical ventilation studies, there's quite a few questions for you, Marcus, so I'm sure there'll be quite a few letters to the editor.
Looking forward to that.
Thank you, Howard. Thank you, Marcus. Howard, please move on. Yeah,
all right.
Thank you.
We'll go on to the next study by Chiara Roba, entitled Results of the ES-ICM Endorsed Stroke Survey on the ICU Management and Admission Criteria of Stroke Patients. Dr. Roba?
Hello to everybody, and thank you for the invitation. I'm Dr. Robba from Policlinico San Martino, Genova, and I'm going to discuss with you the results of the survey that we conducted with the support of ESICM and with the NIC section regarding ICU admission criteria and management of patients with acute ischemic stroke. So a few years ago with Professor Smith, we performed a literature search, and we realized that there are no specific recommendations regarding this topic. There is a huge gap of knowledge regarding ICU management of stroke patients, and we therefore decided to start a process which would have started with a survey, trying to understand which are the main gaps on this topic, and eventually then design some observational studies. So this survey was out in the beginning of 2020 and was composed by 25 items, which were divided in characteristic of responders and hospital ICU information, general ICU information and criteria, and specific aspects of ICU management of these patients. We had 2014 responders, so not many, with a response rate of 16.5%, which is similar to previous survey, from a lot of centers, 198, and we managed to have a picture of a lot of countries all around the world, as you can see from these slides. These countries are importantly different one to each other, with a large heterogeneity in terms of number of ICU beds and the type of ICU. But the interesting thing is that in most cases, acute ischemic stroke patients are managed in general and neuro ICU, and just in few cases are managed in specialized neuro ICU, and are generally managed but not specialized staff, so by general anesthetists, general intensivists, and just in few cases in few countries, Austria or Netherlands, there are a high number of units which are managed by specialized staff. This is the percentage of patients who received the thrombolysis, so it is probably different according to the type and the number of beds of a different hospital. But in general, just in few cases, patients underwent a mechanical thrombectomy, which is common just like in France, Spain, and other European countries. The most important ICU criteria remain the airway management and the need for systemic support or intracranial complications, whereas other indications based, for example, on neuroradiological characteristics or electively after mechanical thrombectomy are less common, and again, there are huge differences among different countries. Patients are generally not neuromonitored when they arrive in the ICU. The first and most important neuromonitoring is the clinical examination and eventually the use of non-invasive methods like transcranial Doppler and EEG to detect early complications from intracranial complications. And let's go to the arterial blood pressure management and in general ICU management. The first thing we asked is whether the clinicians normally use a specific management protocol for acute ischemic stroke, as it is a very crucial point. And again, have a look at the results. In Belgium, USA, Canada, Australia, there are definitely a lot, most or all the responders had declared that they have ABP management protocols, whereas in other countries the use of management protocols is very, very rare. Regarding the targets of arterial blood pressure, here we have some guidelines, some indications from the guidelines. And in fact, as the guidelines, like with a level of evidence 1, suggest to keep patients eligible for thrombolysis with a blood pressure between 185 and 110, this is actually what most of the respondents do. But more confusion is present when the guidelines are not that clear, like in non-thrombolysis eligible and in mechanical thrombectomy, even though a similar target from those who are eligible for thrombolysis is generally used, with a slightly more restricted target for those who undergo mechanical thrombectomy. Ventilation is a crucial component. The main message is that patients with acute ischemic stroke are ventilated with protective tidal volumes. So the concept of lung protective ventilation is gaining interest even in this population. Regarding the target of oxygen saturation, even in this case, most of the responders follow the guideline, which is a good point, and target the SpO2 above 94%, and most of the patients aim also for normocapnia. When a tracheostomy is needed, and which are the indications? The indications for a tracheostomy are those for general neurocritical care patients, so it depends on neurological examination and the ability to protect the airway below a GCS of 8 normally is considered, or respiratory causes like several extubation failures. The problem is the timing of the tracheostomy, as there is still a lot of confusion between late and early. There is a tendency to do tracheostomy a bit late, so after the 8th day from admission, but actually there is an ongoing trial which is going to be published, a randomized controlled trial. We hope this will clarify things regarding this topic. Glycemic control is again crucial in these patients because both hypo and hyperglycemia are associated with poor outcome. In this case, we do have a recommendation from the guidelines, and again, as for the arterial blood pressure, the responders tend to follow the guidelines, so using a target of 140 and 180. The problem is how to achieve this target, because there is still confusion regarding the best strategy to obtain an appropriate glycemic control. And the recent trial SHINE, which basically was a negative trial regarding intensive versus standard control of glucose in acute ischemic stroke patients, showed no beneficial effect at 90 days, and probably this is still related to local policies. TVP prophylaxis is started early, and the most used method is the intermittent pneumatics, and the use of low molecular weight heparin is anyway started early, so within 2 days or 1 day in most of the countries. And if you see here, there are still some difference among countries. For example, in Belgium, the start of low molecular weight heparin seems to be a bit more late compared to other countries, for example, like Netherlands or Greece. Finally, the dysphagia. This is another important point because it's very common in the acute ischemic stroke patients, and the guidelines suggest they mention that it's reasonable to use an instrument for the evaluation of the dysphagia, even though it's not established whether which is the instrument to choose. But in general, what the responders showed is that in most of the cases, dysphagia is a clinical diagnosis, and fiber optic or fiber optic or scores are used just in very, very few cases. I unfortunately had not much time to go in more details regarding the results of this survey, which I believe have given us a good picture of the clinical practice all around the world. However, we have to remember that this is just a survey, so we don't know, we did not have the control of the number of responders for each country, and this lead to the fact that these results are difficult to generalize. There are also some information, several information, which are actually missing. This survey came out exactly during the first wave of pandemic, so probably now the treatment and the management is a bit different. And as I was mentioning at the beginning, what we need are more structured studies, observational and randomized control trial. So in the total absence of literature regarding this point, we decided to start with a prospective study, which is called the Stroke ICU study. This study is an observational intervention study just with the aim to obtain a proper picture of which is the clinical practice and to assess also the differences among countries. We had some information with this survey, but these are obviously not enough. This study has been endorsed from the ESICM. We believe that it's probably wiser to wait until the end of the pandemic before starting the study, but in the meantime, I thank you for your attention.
Thanks, Chiara. Congratulations. So a couple questions. Your fourth bullet on limitations was the critical issue, and you acknowledge it, which is wonderful. So the peer reviewers and the journals won't, but you acknowledge that you got the opinion of a single individual who was generalizing to an entire intensive care unit, and you have no idea if the way that individual completed the survey is what actually happens. And that obviously is the biggest issue. But here's my more precise question. When you think of all of the questions that you asked, let's assume for the time being that the responses are accurate and they're valid. What was the biggest surprise for you? And when you think about your ongoing prospective study, have you used that information to try to focus on those questions that you think are critical? Because the more you ask people to do in a registry, the less likely it will get done. So rather than asking 20 questions, did the survey help focus the prospective study?
Yeah, thank you for this question. And it's a pleasure to be here, first of all. Hello. I think this is the real crucial point of making surveys. I don't think that we should make surveys to answer big questions. I think we should make surveys to focus the CRF of our prospective studies in a way that it could be simple for each center to fill the data, but to have focused and important questions that we want to be answered. In this case, for example, this survey, I think that the major issues, so where there were more doubts among countries, etc., was the ventilatory strategies, the ventilatory targets, and the use of tidal volume, of PEEP, etc. Another crucial point was, for example, the HB threshold. So let's say all the facts which are still unclear in general in neurocritical care, where there are not big trials, where there are not big observational studies, and where the guidelines are lacking. Because, for example, for ABP management, we have some guidance from the guidelines. And I have to say that, for example, for these questions, most of the responders agreed with the guidelines. For the rest, it's just about our clinical practice. So this survey basically really helped us to design the observational study. And I hope that the observational study then will help us to design a possible randomized control trial.
And Chiara, just a follow-up question. So you saw differences, regional differences from different places in the world, I think within Europe, within different countries, and then North America, probably Australia and New Zealand. when you select sites to participate in a prospective study, obviously they have to agree. But will you try to make sure that you have a reasonable distribution that represents what you found to be inconsistencies between areas of the world? So again, is this kind of preliminary survey going to influence where you select sites to participate in the prospective cohort study?
Definitely yes, because we would like to have a proper picture of what is happening all around the world and in different countries. We are lucky because with a mixed section, we have run in the last years some big observational studies, like for example the Synapsis studies, and now we are starting VentiBrain study. And now we have created a sort of network of neurointensive care units from all over the world. So for example, for VentiBrain, we have a lot of centers from Australia, from India, from Africa, from South America, North America. So the building this network has really helped us to create a group who work together, who is committed, are happy to work for further projects, and they allow us to have a real representation of the differences between countries.
Thanks, Chiara. I'm going to turn the podium back over to Yosef. Stay healthy and thank you.
Thank you. Charlie Sprung will, from Jerusalem, Israel, will present the study results of adult ICU triage during the coronavirus disease 2019 pandemic.
I am presenting ICU triage during coronavirus pandemic, and I have no conflicts of interest. In March, the WHO declared COVID-19 a pandemic. In many countries, the systems were overwhelmed with the lack of adequate ICU beds, ventilators, or PPE, and many patients died. Various medical societies offered guidelines for ICU triage, which included social worth or chronological ages in Italy. There had been several recommendations for the use for various epidemics, but these did not seem to be appropriate for the current pandemic with all the different problems. I contacted several colleagues in China, Italy, and Spain and found out that the situation was terrible. I contacted other colleagues who I had worked with previously for ICU triage in normal and epidemic situations to see if we could perhaps update a protocol for the current pandemic. We came up with a new tool, mostly with input from the countries that were hard hit by the pandemic. And here are some of the main recommendations that we had. Institutions should develop prospective objective protocols to enhance consistency and decrease provider moral distress. Available resources should be maximized, and the triage protocols should be triggered only when resources across a broad geographic area are or will be overwhelmed. The strategy was for the greatest good for the greatest number of patients, looking for an incremental survival benefit of those who were admitted to the ICU as opposed to not being admitted to the ICU, and attempting to save the most life years. If different patients had equal priorities, we would use a first come, first served basis. The algorithm that we came up with had to be simple, easy to understand and use, and most important, providing for quick assessments. The triage algorithm we're using applied to ICU triage for COVID patients, but also for non-COVID patients. We use the same exclusion and inclusion criteria as used under normal circumstances, so people would not feel that they had a life that was of lesser worth and could still have an opportunity to be admitted to an ICU. We started with the exclusion criteria. If a patient met those exclusion criteria, we didn't have to move on and we could triage to the next patient. The prioritization score had 4 different sets of variables predicting short-term mortality. The first was the ECOG performance score, a score developed for oncology patients, but found to predict mortality in older patients, in patients with pneumonia, and a various group of ICU patients. We chose this score because there are only 5 variables as opposed to the 9 variables found in the clinical frailty score. Comorbidities, we used the ASA score, which was concise, logically arranged, and much quicker to use than previous algorithms that used comorbidities with various lists of diseases. As far as organ system failure, we were just looking at the numbers. We decided against the SOFA score, which was complex, had been found not to be reliable looking at previous epidemic data. And in general, the patients coming to the emergency room with COVID only had organ failure problems with their lungs and not multiple organ problems. And again, the clinician would decide on the predicted survival to help make a decision about the priority score. Now, we wanted our protocol to be flexible so that one could adapt to the local practice using one, let's say the clinical frailty score as opposed to the ECHO performance score if necessary. Age should be taken into consideration with other variables, but should not be the sole determining factor. In terms of priority for healthcare workers, this was controversial, and we decided each country should decide for themselves. As far as having a triage committee based on making the ICU decisions as opposed to the primary intensivists, we thought this would depend, again, on each country. Most important was staff protection, which should be included as a major priority. Now here we see the algorithm. You can see on the top left the exclusion criteria and then the inclusion criteria and the 4 priorities. If one had severe underlying diseases, metastatic cancer, they would have a priority 4. They would be included, but would probably not make it to an ICU if they had a severe pandemic, as opposed to priority 1, which had a very low performance score and pretty much few, if any, underlying diseases. Here's the ECHO performance score, which you may not be familiar with. If you have a 0, a fully active person, as opposed to number 4, someone who could not take care of themselves and was bed-bound or in a chair all the time. Now here is a paper that was published online in Critical Care Medicine in May. It has many, many more recommendations if you are interested. Now let me change gears a bit and talk a little bit about what happened in my country, in Israel, which actually developed a national ICU and ventilator triage program for the entire country. At the end of March, Hadassah, the hospital where I work, decided on having an ethics committee to make triage decisions. As this was a national problem and not just one for one hospital, a decision was made by the Israel Critical Care Society and the Ministry of Health to try to develop a protocol for the entire country. A few days thereafter, the Director General of the Ministry of Health appointed Professor Steinberg, who was the chairman of the National Bioethics Council, to develop national guidelines to triage patients if the healthcare system was overwhelmed. This was made up of a joint commission of the National Bioethics Council, the Ethics Bureau of the Israel Medical Association, and the Israeli Ministry of Health. There were 4 subcommittees: the medical, legal, philosophical, and halachic or religious, which made up a group of people representing the society, experts in each one of these fields. So let me talk a little bit about the Israeli guidelines. They provide general principles, pragmatic medical criteria with a practical triage protocol. The general principles included supreme value of life, equal access to various individuals, transparency, consistency, equity in access, fair distribution, the greatest good to the greatest number, and compassion to all patients while promoting public trust. Looking at the general public, we tried to give explanations for the necessity and application of excruciating decisions in extraordinary circumstances while preserving mutual trust. For the healthcare professionals under extreme duress, the provision of succinct practical algorithms. Now, here are some of the main points. The triage guidelines take effect only after the Ministry of Health declares a transition to an emergency state after all efforts to obtain additional resources fail. The prioritization is solely based on an individual basis without any discrimination based on a group. Prioritization only on a medical basis and short-term survival, not according to remaining years of life. And again, we looked at several tools, and we ended up using a similar algorithm used in the critical care medicine paper. We typically use the same exclusion and exclusion criteria and prioritization variables as the critical care medicine paper. Now, some differences: age, chronological age is not a legitimate standalone criteria for triage and should be considered with other risk factors. And the goal is the number of lives saved rather than life years saved. Healthcare professionals should not be given upfront priority, even if infected by COVID patients, and only if absolutely necessary to overcome staff shortages, and only then a tie with other patients. Now, most important, the state will ensure a fair distribution nationwide of ICU beds, ventilators, and skilled personnel according to population density and expected actual demand. And for Israel, we decided that there should have an institutional triage committee only for consultations. Now, this was an important recommendation because these led to national policies. And as you can see here, the chess paper gives recommendations which can be used by other countries to make national guidelines. What I've tried to do today is give you some ideas about ICU triage and a national policy which can help you make decisions. Thank you very much.
Thank you very much, Charlie, with this presentation, which addresses a situation that we were faced daily the last 10 months in our clinical life. I would like to ask one question concerning the ICU admission criteria. And you had actually shown a very nice slide with 4 priorities, very clear cut. Which can be a very nice guidance if the situation, how severe it may be, stays constant, because it can dramatically change with the numbers coming in, you know. What I mean is that the norms that people were having in Italy in March could be completely different in Italy in November, also for other countries. So how would you interpret such a chart with clear-cut steps, or how could you expect that this could be modified according to the needs in a very fluctuating number of patients coming in COVID-19 situation ICUs?
So I would emphasize the fact that this is to be used only under circumstances where the system is overwhelmed. Under normal circumstances, and even in COVID-19 circumstances, I think most of us are still using our usual triage mechanisms. But this was developed mostly with the help of Jordi Rello, who was really overwhelmed in Barcelona and was telling us stories that he had patients in the emergency room who they would just come in and that they just couldn't even get to triage of the patient before they would die. So that was the impetus for making the score as quick as possible, using simple modalities that we would be able to move very, very quickly to the next patient. And Jordi described the fact that practically all the patients were in a priority 1, and forget about, priority 4. Some of them, they wouldn't even get to priority 2 or 3s because practically all the patients coming in were priority 1s, and they just had to make a quick decision about who to take or not.
Thank you. There is one important question, I think. The question is, could one be discharged from ICU or the intensive therapy ended according to the triage guideline when another person who has only a little better score comes as a candidate in the emergency department?
So the algorithm we're using is mostly for an admission. We discuss in the paper the discharge, and the discharge should typically be done not quickly, probably should be done by senior people and probably by more than one physician. And we don't want a quick decision and rotations of patients out unless it's clear that that patient is not getting better, is deteriorating, and is no longer benefiting from staying in the intensive care unit.
Yeah, I think for the audience to clarify, if I read the question more and more, it means whether you would discharge somebody just because there is somebody else is coming, which has a little bit more chance to survive. And I think you have answered that you discharge only according to other norms and not because somebody else has a little bit more chance, right?
That's correct. We have a certain obligation to the patients already in the intensive care unit, and we want to make sure that they've had a fair chance to get better.
Okay. I have one last question. Is the ASA score used for patients having anesthesia applicable to use for triaging a modern-day critically ill population?
So we were looking for something quick and easy, looking instead of long lists of comorbidities, and we felt the ASA was probably quick and easy and helpful enough to make those quick decisions. We kept hearing Jordi tell us what was going on in his emergency department, and we just wanted to move as quickly as possible and not, I mean, when you look at some of these lists, I mean, you have 2 or 3 patients waiting, you don't have time to go through lists, and ASA is very quick.
Thank you very much, Charlie. I will, with this, hand it over to Howard for the next presentation. Thank you.
Thanks, Charlie. Stay healthy. The next presentation is by R. Stevens Robert, Mechanical Ventilation and Acute Brain Injury, Recommendations of the ESICM Consensus Conference. Robert.
Ladies and gentlemen, my name is Robert Stevens, Johns Hopkins University, Baltimore, Maryland. It's my great pleasure to present on behalf of my colleagues the ESICM Consensus Mechanical Ventilation in Patients with Acute Brain Injury. This project was endorsed by the Executive Committee of the ESICM, and my disclosures are shown here. The outcome of this group was presented in a special edition of Intensive Care Medicine, which is appearing this month, and I'm giving you the reference here. So the rationale for this work is that mechanical ventilation is a cornerstone in the management of patients admitted to the ICU with severe brain injury. We know that mechanical ventilation can have both beneficial and also deleterious effects on cerebral physiology, on cardiopulmonary physiology, and on clinical outcomes. However, there is significant uncertainty about the best practice for mechanical ventilation in this population. So accordingly, the aims of this consensus were twofold. One, to provide clinical practice recommendations for respiratory support and mechanical ventilation in this population, and secondly, to identify knowledge gaps and generate a scientific agenda. So this slide illustrates the methods and timeline of this project. Inception was in spring of 2019. The panel was selected and finalized by June of last year. From June to December 2019, we proceeded with systematic reviews and meta-analyses, and we had elaborated the initial versions of the statements. The panel met in person at the ESICM Lives meeting in Berlin in October of 2019. From January to May 2020, the panel underwent the Delphi voting process, and over the course of this past summer, the consensus recommendations were finalized and the manuscript was submitted to be published this month, as mentioned. We assembled an international multidisciplinary consensus panel. This was composed of clinician scientists with expertise in neurointensive care, respiratory failure, or both. We also were fortunate to include 2 non-voting methodologists who advised on meta-analysis and on Delphi approach. The panel was divided into 7 groups, each tasked with answering a specific question, and they met by scheduled conference calls. This slide shows you the composition of the panel. I would like to acknowledge my consensus co-chair, Dr. Chiara Roba, and also acknowledge the wonderful work of all the panel members over the course of the past year and a half. This slide shows the different clinical practice domains that were addressed by the consensus. First, what are the indications for endotracheal intubation? Second, is it safe and effective to use non-invasive respiratory support? Third, should we use specific mechanical ventilation settings? 4, should we target specific arterial blood gas values? 5, is it safe and effective to use rescue interventions to support patients with severe respiratory failure? 6, what are the criteria for ventilator weaning and extubation? And 7, what are the indications and optimal timing for tracheostomy? These 7 questions are overlaid here on a diagram illustrating the trajectory of the patients of interest. These are patients with acute brain injury and acute respiratory failure. They can be managed either with intubation and invasive mechanical ventilation. In some instances, they can be managed non-invasively. In cases of severe respiratory failure, they may be candidates for rescue therapy, such as prone positioning or ECMO. And at the end of this trajectory, these patients are liberated either through extubation or through tracheostomy. We conducted a series of systematic reviews. We included studies of patients admitted to the ICU with acute brain injury. So we defined acute brain injury as patients with either traumatic brain injury or cerebrovascular injury, meaning ischemic or hemorrhagic stroke. We excluded studies of other neurointensive care populations, for example, patients with status epilepticus. And we focused only on those studies that reported on relevant outcomes, meaning either clinical endpoints or physiological endpoints. The decision rule for consensus on recommendations is shown here. We felt that there was a strong recommendation if greater than 85% of the panel was in agreement, that the recommendation was a weak one if 75 to 85% of the panel were in agreement, and there was no recommendation if less than 75% of the panel was in agreement. In the following slides, I'm providing you with some of the recommendations of the panel. First, in regards to intubation, the panel felt that this needs to be a multifactorial decision process that considers the level of consciousness, presence of agitation and combativeness, loss of airway protective reflexes, and elevation in intracranial pressure. Regarding the use of non-invasive strategies, the panel was suggested that high-flow nasal cannula can be considered in selected patients. On the other hand, it was unable to make a recommendation on the use of non-invasive positive pressure ventilation in this population. Regarding the use of specific mechanical ventilation settings, the panel felt that the use of PEEP and lung protective ventilation should be applied as in patients without acute brain injury in the setting of absence of intracranial pressure elevation. On the other hand, in patients with intracranial pressure elevation, the panel was unable to make a specific recommendation. Regarding the use of the targeting of specific arterial blood gas values, the general consensus was that we should target normoxia and normocapnia. On the other hand, the panel was unable to make a specific recommendation on the use of hyperventilation as a therapeutic option in patients with significant intracranial pressure elevation. As far as the use of rescue interventions, the panel was in favor of prone positioning and of short-term neuromuscular blocking drug infusions in selected patients with severe ARDS. On the other hand, the panel was unable to make any specific recommendation on ECMO or on recruitment maneuvers in this population. Regarding the criteria for weaning and extubation, as with intubation, the panel felt that decision to extubate should be multifactorial. It needs to consider the clinical trajectory of the underlying neurological condition, the level of consciousness, presence of airway protective reflexes, and factors relevant to extubation of non-neurological patients. The panel was unable to identify a specific Glasgow Coma Scale threshold for extubation in this population. And regarding tracheostomy, the panel was in favor of considering tracheostomy in patients with acute brain injury who have failed one of several trials of extubation, and in patients who have a persistent depression in consciousness. They were not able to identify a specific timing for tracheostomy. As regards the scientific agenda, so there were a few considerations. First, regarding study design and endpoints. The panel felt that future studies need to stratify by brain injury etiology, so for example, separating trauma from stroke, from subarachnoid hemorrhage, and also consider clinical severity. The panel was in favor of conducting both pragmatic and also explanatory trials, and considering techniques such as prognostic enrichment and predictive enrichment to enhance the likelihood of demonstrating treatment effect. As far as endpoints of interest, the panel felt that we should focus on efficacy endpoints. So these are looking, for example, at physiological changes as well as clinical outcomes, but also the panel was in favor of looking at factors such as safety, feasibility, risk benefit, and cost benefit. The 4 different clinical scenarios were identified for future studies. This is patients with acute brain injury, patients with acute brain injury who have ICP elevation, patients with acute brain injury and acute respiratory failure, and patients with acute brain injury and ARDS. So in summary, this consensus proposes some guidance for clinicians on mechanical ventilation and respiratory support in critically ill acute brain injury patients. Overall, we found the evidence to be of low quality or lacking across the different domains studied. We feel, therefore, that there is an urgent need for innovative and high quality research to improve the care and the outcomes in this population. And certainly a promising direction is the possibility of personalizing therapy based on patient-specific clinical and physiological features. So with this, I would like to conclude this presentation, and I would like to thank the ESICM, as well as all the members of this panel who worked very closely with me in generating this consensus. Thank you.
Thanks, Robert. Presentation incredibly clear. Thank you. I have 2 questions that are related. As you listed all the categories, I think there was only one where there was moderate evidence. So the first question is, were you surprised that it's not little evidence? It appears as though there's virtually a total lack of evidence. So one, were you surprised about that? And then secondly, EBM folks cringe when you give strong recommendations with no evidence. Now, that contrasts with clinicians who have to make decisions. But there were many, many, many strong recommendations with no evidence. And I didn't know how you justify that. And that always gives pause to people. So because they can become quality indicators, which you know, probably more in the US than other places around the world. So were you surprised by the lack of evidence, virtually total lack of evidence, and this disconnect of strong recommendations for maybe 20 recommendations with no evidence?
Yeah, thank you, Howard, for those questions. So we were surprised in parts. Many of us who've worked on this consensus were familiar with the literature ahead of time. We did a very systematic review, and we did meta-analysis. We were, in the end, very disappointed with the quality of evidence, and so we were partly surprised, not completely surprised. I think the main message is that this is a call to perform higher quality research in bigger cohorts of patients using modern clinical trial techniques. And in regards to making recommendations in the absence of evidence or with very low quality evidence, this is really ultimately was the decision that was made collectively by the group. There were certain instances where the group felt very strongly in favor of some interventions, acknowledging that the evidence was very low, but the thought was we need to be pragmatic and provide some guidance in some instances. In other instances where there was really quite a bit of clinical equipoise, we refrained. I guess the group collectively felt that there was not enough, opinion and not enough evidence to support a specific recommendation. But I think if you look across guidelines, in intensive care and in other domains of medicine, that scenario of having strong recommendations in the absence of strong evidence is not uncommon.
Yeah, we've published a few, and whenever we see that, we actually ask the writers of the recommendation statement to justify why they've made that recommendation. So at least clinicians then have a sense of it. If you had changed the criteria, and I've forgotten what they were, I think it was greater than 75%. If you had changed it to greater than 90% in the Delphi process, would the number of strong recommendations based upon no evidence change substantially, or is it hard for you to remember that, Robert? I'm just curious because you do make up arbitrary cutoffs, and so if you would change the cutoff, would
so
the same...
The cutoff was 85% for a strong recommendation. And I think we did a sensitivity analysis, and we found that even if we had a more stringent cutoff, there would not be a significant change in the number of recommendations that had that strong approval by the group. So I think ultimately we did in the manuscript as well strongly emphasize that the evidence was weak in many, if not most cases. And as I mentioned earlier, this should be a strong message to all the members of this community who are interested in this particular population, that we need to do research, we need to gain better knowledge about these patients to generate stronger data to support practice. But in the meantime, we wanted to provide some pragmatic advice for clinicians who are in the front lines.
And just a last question, when you're in the Delphi a pragmatic approach, then you go and have coffee, and then you hear the real discussions over coffee or at dinner. And people begin to say, this is really the most important question. Like, if we could answer this question, we could really improve care. So if you had to list 2 or 3 questions that you think the wisdom of this group would come up with, what would they be?
Yeah, I think there's really 2 fundamental questions. One of them is the impact, the physiological impact of mechanical ventilation on cerebral parameters, and how we can, in a way, leverage mechanical ventilation as a strategy to improve not only short-term physiology, but also longer-term outcomes. I'm thinking in particular about lung protective ventilation. That's number 1. So the second fundamental question is liberation. I think there's a great deal of clinical uncertainty, equipoise about how best to wean and extubate, liberate these patients from ventilation. And I do think that there is, we're meeting actually in 2 days, an international group to discuss how we can set up a appropriately designed clinical trial to answer the question how best to not only identify targets for ventilator liberation, but also to personalize that ventilator liberation.
Thanks, Robert. It's a difficult area for clinical care. So I do appreciate the need to not just simply say you can make no recommendations. That doesn't really help the clinical world very much. Congratulations.
Thank you very much.
I'll turn it over to you, Seth.
Thank you. We are coming to an interesting issue, the vitamin C, thiamine, and steroids in patients with sepsis. The VICTOS randomized clinical trial will be presented by Sevransky from Atlanta.
I would like to thank the conference organizers and the moderator for the opportunity to present the preliminary results from the VICTOS trial, the effect of vitamin C, thiamine, and hydrocortisone on ventilator and vasopressor-free days in patients with sepsis. You can see here my financial and intellectual disclosures. This study was funded by the Marcus Foundation. Sepsis is common, potentially lethal, and requires timely therapy. We know that early identification of patients with sepsis, in conjunction with early antibiotics and performance improvement projects, have all been shown to improve patient-centric outcomes. However, ancillary therapies have not yet been proven to definitively improve mortality. There is substantial biologic plausibility for the use of vitamin C, thiamine, and steroids in sepsis. Vitamin C and thiamine levels are low in sepsis. Vitamin C has known anti-inflammatory properties, and it's also involved in catecholamine synthesis. And the use of vitamin C, thiamine, and steroids in sepsis may potentially be synergistic. Importantly, all three of them are widely used, they're low cost, and at least some small trials have suggested a benefit. That led us to design the Victus trial, which was initially funded for 500 patients by the Marcus Foundation. And it was designed to enroll patients with confirmed or suspected infected and evidence of infection causing either respiratory or cardiovascular dysfunction. The intervention was intravenous vitamin C, thiamine, and hydrocortisone at fixed doses every 6 hours until 4 days or ICU discharge, whichever came first. The comparator was placebo, unless the clinical team thought it essential to give open-label steroids, in which case the investigational pharmacist at the site would hold study drug 3, which was either placebo or hydrocortisone. Our primary outcome measure was vasopressor and ventilator-free days, with this number being set at 0 for patients who died in the hospital prior to 30 days. And an important secondary outcome measure was 30-day mortality, since mortality is more likely to change physician behavior. The inclusion criteria, again, were a suspected infection, defined as blood cultures being drawn and antibiotics being given, and both the study team and the clinical team needed to think that the respiratory or cardiovascular dysfunction was caused by sepsis. Patients could be enrolled in the emergency department, the wards, or the ICU, but if the patient wasn't in the ICU, there needed to be an anticipated ICU admission. The exclusion criteria are listed here and primarily included those patients who had chronic respiratory or cardiovascular support, in which case they would not be able to develop the primary outcome measure, or those patients who did not want to receive either cardiovascular or respiratory support. For the early interim analyses of the study, the Data Safety Monitoring Board would only stop the study for mortality, and relatively low amounts of alpha were expended on these early interim analyses. The study was designed adaptively using what our statistician called a bypass Goldilocks approach, so that if we showed vasopressor and ventilator-free days, which was measured after 500 patients, that the study could potentially continue if it was neither very likely or unlikely that we would show mortality, even if vasopressor and ventilator-free days were hit the stopping rules. We recruited patients relatively briskly, with the first patient being enrolled in August of 2018 and the 500th patient being enrolled in July of 2019. Any study has challenges, and we had a few. One of them was that there was a thiamine shortage that occurred nationwide during the course of the study that limited enrollment because we couldn't get thiamine. The most important challenge that we ran into was that the funder became impatient and decided that they did not want to wait another 18 to 24 months to see the study results, and they therefore declined to fund the additional 1,500 patients. We screened a little over 3,200 patients to enroll 501 patients. The most common reasons for exclusion were the need for organ support from something other than sepsis, the need for home oxygen, patient or surrogate refusal, and limitations in care. We included 417 patients in the per protocol analysis, and the main reason that patients were not included in this analysis was not having received the at least 4 doses of study drug, which was prospectively determined. The median age of enrolled patients was 62 years, 46% were female and 30% were Black. Median baseline Apache 2 and SOFA scores were 27 and 9 respectively, and the median time between onset of qualifying organ dysfunction and the first dose of study drug was just under 15 hours. Of note, roughly a third of patients in the intervention and control groups received open-label corticosteroids, and as a reminder, for those patients, study drug 3 was not administered while they were on open-label corticosteroids. For our primary outcome measure, there was no statistically significant difference between the intervention and control group in vasopressor and ventilator-free days. For exploratory outcomes in the primary analysis and the per protocol analysis, there was no difference in patient-centric outcomes such as 180-day mortality, length of ICU stay, length of hospital stay, and this was again the case in both the primary analysis and the per protocol analysis. No difference between the 2 treatment groups. When you look at survival, and I should note that on the y-axis that should read survival rather than death, the treatment group is shown in yellow, the control group is shown in black, and there's no difference in 30-day or 180-day mortality between the groups. I've mentioned some of the study limitations. It was administratively stopped due to lack of funding and thus potentially underpowered to detect clinically meaningful differences in patient-centric outcomes. We used a fixed dose of vitamin C. It's possible that a higher dose or dosing based on plasma vitamin C concentrations could have led to different results. It is possible that earlier treatment with vitamin C and thiamine and steroids could have led to different results. And as noted, clinicians were allowed to give corticosteroids at their own discretion, which roughly a third of the clinicians did, which could have biased our results. So in conclusion, in critically ill patients with sepsis, treatment with vitamin C, thiamine, and hydrocortisone compared with placebo did not significantly increase ventilator and vasopressor-free days within 30 days. Thank you, and I'd especially like to give thanks to the patients who enrolled in the trial, as well as the investigators and coordinators at the 43 enrolling sites. Thank you very much.
Thank you very much, John, for this very nice presentation. Let me first ask a question on the comment that you made that the study could have been underpowered. And before that, you also mentioned that there were 500 patients included, but considering the time that it took for inclusion, the funding for the next 1,500 patients were not being provided, right? So this is maybe one of the reasons of the underpowering, because I don't know the power calculations and etc. Of course, I can't follow that. But I'm just looking at it from the ethical aspects. I mean, if you know that there is no funding for the next 1,500, can we not just make a speculation that the first 500 patients were exposed to study risks without having any hope that we would be achieving something, because the study was underpowered? But this is a little bit too challenging. I just want to know your opinion on that.
Surely. So, and you've highlighted again the major concern for the study. In actually we designed the study to enroll up to 2,000 patients. In actually the study consent form, we mentioned that we enrolled, that we were planning on enrolling at least 500 and up to 2,000 patients. But I agree that funding and completing a study is always a tremendous challenge, and here it proved to be a bigger challenge. So I'm not sure that I have anything more useful to say about that, but you have again highlighted one of the major concerns. Perhaps I guess the one thing I would say is that if we knew definitively at the beginning that we were going to just have 500 patients, it is possible we might have chosen a different primary endpoint.
Okay, just a short question. I heard you also commenting that the treatment was not as early as expected. Earlier treatment might be more beneficial. And this is something that also we heard 1 year ago as comments to the Australian study. Why do you think that this was the case in your study? Knowing that earlier treatment might provide more beneficial effects.
So that's a wonderful question, and we did a post hoc exploratory analysis looking at whether or not there was any signal toward more benefit in those that were treated earlier, and in fact did not see that in either the intervention or the control group. So it is possible again that there is might be a benefit. Our trial gave therapy a little bit earlier than in the vitamin study, but again the post hoc analysis looking at time to treatment did not show a significant association between time to therapy and clinical outcome.
Okay, I have one last question here from the audience. Do we have enough conviction to try high doses of vitamin C in terms of a trial or otherwise, since fixed dose have turned negative? Probably he means higher dose, but yeah.
So that's a wonderful question. And I think that our study can neither definitively prove nor refute the fact that vitamin C at a fixed dose is beneficial, again, because it is underpowered to show the treatment effect that we looked for. There is a smaller study that was the citrus ALI study that did use a higher dose. And there is an ongoing trial in Canada, the Lovett trial, that is looking at a higher dose. So I think, again, that we can neither prove nor refute the possibility that that vitamin C is useful for patients. In a post hoc or at 500 patients, there was roughly a predictive probability of 30% that we would be able to, at 2,000 patients, if the study was fully completed, show a difference in vasopressor and ventilator-free days. So again, it's an interesting question. I'm not sure it's been answered.
Okay. Well, Howard, I would like to hand it back to you for the last presentation.
And before I introduce the next speaker, Josef, I just want to take this opportunity. I think this is the third time we've chaired the late breaker session. It's really been a privilege. And I want to thank you for inviting me each year and for your extraordinary service to ESICM. And I'm sure you'd get a round of applause from the audience, but unfortunately, there's no audience. On to the last presentation by C. Dale. It's entitled Impact of Oral Chlorhexidine De-adoption and Implementation of an Oral Care Bundle on Mortality from Mechanically Ventilated Adults, a Step Wedge Cluster Randomization Controlled Trial. Craig?
Hello, colleagues. My name is Craig Dale, and on behalf of my co-principal investigator, Dr. Brian Cuthbertson, I'm honored to present on the impact of oral chlorhexidine de-adoption and implementation of an oral care bundle on mortality for mechanically ventilated adults, a stepped wedge cluster randomized controlled trial called the CORAL study. I would like to thank the organizing committee for this special opportunity to present our study results today. We have no actual or potential conflicts of interest in relation to this program or presentation to report, and here are our sources of study funding. I'd like to acknowledge the CORAL investigator team, many of whom you may recognize by name, for their essential contributions to this study. I'd also like to acknowledge the site study leaders and champions. Without their enthusiastic support, this study would not have been possible. With respect to study background, patients developing infection-related ventilator-associated complications, also called IVACs, are at high risk for poor outcomes, including development of ventilator-associated pneumonia, or VAP, which is defined by infection of the pulmonary parenchyma in patients exposed to invasive mechanical ventilation for at least 48 hours. This is reported to affect between 5 to 40% of patients and is associated with increased mortality as well as greater costs and duration of treatment. Processes of care to prevent VAP often target oral health dysfunction, which is common during mechanical ventilation and worsens over time without adequate intervention. Oral health changes do unfortunately provide favorable conditions for overgrowth of pathogenic gram-negative bacteria, which, if aspirated, can lead to VAP. Initial concerns about the association between VAP and adverse patient outcomes led to the introduction of the VAP bundle. This bundle was intended to consolidate multiple treatments into one care package to be systematically implemented. Here you can see a familiar list of key prevention strategies. Among these is oral chlorhexidine rinse to control bacterial overgrowth. Oral chlorhexidine has been extensively studied in the ICU, and meta-analysis of open-label studies suggest it lowers VAP rates, but meta-analysis of double-blind studies demonstrates no impact of chlorhexidine on VAP. Although the evidence base supporting chlorhexidine is mixed, cross-sectional surveys demonstrate up to 70% of ICUs in Europe and North America have adopted daily oral care with chlorhexidine as a simple, low-cost approach to VAP prophylaxis. Notwithstanding its high use in practice, recent publications have challenged our presumptions about the safety and efficacy of daily oral care with chlorhexidine. These concerns include an unexpectedly high rate of oral lesions in patients exposed to 2% chlorhexidine and evidence of reduced VAP pathogen susceptibility to this agent. These disadvantages may increase procedural oral pain due to disruption of oral mucosa integrity and possibly contribute to an increased risk of oral systemic infection. Most serious among the concerns discussed in the literature is the unexpected signal of excess mortality. For example, Price and colleagues conducted a network meta-analysis including 11 studies which demonstrate chlorhexidine is associated with an increase in mortality in adults with an odds ratio of 1.25. These findings have raised considerable uncertainty about continued use of oral chlorhexidine rinse. And many of our colleagues in Canada engaged in conversation about proactive de-adoption of chlorhexidine to mitigate this risk. However, there remains ongoing concerns related to the appropriate oral care regimen to put in place to prevent patient complications. These concerns led us to consider a large multi-center trial and the design of the CORAL study. In the CORAL study, our hypothesis was that de-adoption of chlorhexidine and implementation of a standardized oral care bundle would reduce ICU mortality, IVACs, and procedural pain whilst improving oral health status for our patients. We used a step wedge cluster randomized controlled trial design to evaluate the impact of this intervention with an embedded process evaluation to understand fidelity of the intervention. We recruited 6 adult intensive care units to participate. All clusters, defined as individual ICUs, commenced the study with a 2-month control period comprising 0.12% chlorhexidine oral care, which was pre-existing baseline practice. Clusters rolled over into the intervention period in a stepwise fashion every 2 months, according to a computer-generated randomization schedule. At study completion, all clusters had fully de-adopted chlorhexidine and implemented the standardized oral care bundle comprising oral assessment, toothbrushing, suctioning, and moisturization. Recruitment of over 4,000 patients in over a 14-month period would have provided 80% power to detect an absolute mortality difference of 5% or greater. The study design adopted a multifaceted approach to implementing the oral care bundle, including point-of-care education, audit and feedback, reminders, and oral care champions embedded in each unit. Our research questions included: 1, what are the effects of oral chlorhexidine de-adoption and the introduction of an oral care bundle on ICU mortality? 2, what is the change in IVAC rates, oral health dysfunction scores, and procedural oral pain following the adoption of oral chlorhexidine and the introduction of an oral care bundle? And 3, what is the compliance with the oral care bundle that may explain the study results? Based on our hypothesis and study questions, the primary outcome was ICU mortality. Our secondary outcomes are listed here and were measured with validated tools. Intervention fidelity appraised delivery of chlorhexidine and oral care bundle components during control and intervention periods using trained independent observers who entered each unit on a randomized schedule. With respect to study results, here are the patient characteristics. We recruited 3,260 patients with 1,560 in the control period. This group received chlorhexidine oral care. And 1,700 patients in the intervention period. This group received the new oral care bundle without chlorhexidine. Patients were similar in both study periods with respect to age and sex. However, as is common in cluster trials, we observed differences in demographic characteristics, and this was observed for Apache 2 score and diagnostic categories, operative status, and the number of comorbidities. After adjusting for differences in baseline characteristics, we found no difference in ICU mortality between control and intervention periods. Time to IVACs did not differ, and procedural pain was not significantly changed. However, oral health dysfunction scores significantly improved in the intervention period. Random observation of intervention fidelity in over 340 oral care encounters demonstrated successful de-adoption of chlorhexidine in the intervention period. We observed significant increases in all oral care bundle components between control and intervention periods. More specifically noted, greater than 72% of patients received toothbrushing, suctioning, or an oral moisturization components regularly. In this step-wedge cluster randomized controlled trial recruiting 3,260 mechanically ventilated patients across 6 Canadian adult ICUs, we found an intervention comprising de-adoption of chlorhexidine and implementation of an oral care bundle did not support our hypothesis of reduced ICU mortality, IVACs, or procedural pain. However, the results demonstrated improved oral health scores during the intervention period. To our knowledge, this is the largest prospective trial of chlorhexidine prophylaxis to date. Nonetheless, there are important limitations. Our final patient recruitment fell short of the number of patients anticipated in our sample size calculations, and the trial was unable to rule out the possibility that the adoption of chlorhexidine was associated with an increase in mortality. Although the study does not show equivalence or non-inferiority for oral chlorhexidine over a standardized oral care bundle, the results do question the benefit of this agent in mechanically ventilated patients. Clinicians may decide to impose a moratorium on the use of chlorhexidine until further evidence supporting its efficacy and effectiveness becomes available. It seems reasonable to adopt an oral care bundle into practice since there is evidence of benefit and low risk of harm. I'd like to thank you very much for your generous attention, and we look forward to your questions.
I just want to let the audience know we're joined by Brian Cuthbertson, who's another one of the investigators. So congratulations. These are really difficult trials to do. You have to try to make sure people are actually doing what you think they're doing. You really did well on fidelity. But I have a more kind of clinically oriented question for either Craig or Brian. It seems to me that clinical care at the bedside, it's not chlorhexidine or oral care bundles. That mostly nurses or support staff do both. They don't do one or the other. And I'm just curious, like, what happens in real life?
Well, in Canadian ICUs, it's the nursing staff who deliver all of the oral care, and it's typically timed. So with regard to chlorhexidine, it's prescribed at certain intervals throughout the day. And in our study units, it was 4 times a day. And so they're just responsible. But typically, you're right, in terms of its monitoring, it's something that's not necessarily documented well. And what we've discovered, it's not delivered well. So in real life, it's highly variable practice.
But Craig, I guess just to follow up, and then I'm curious what Joseph would say about this. You know, when there's time, you would prescribe chlorhexidine, but nurses would also do some elements of this oral care bundle, right? It's like extra credit, right?
Right. But we did find a couple of things that are important for the audience to note is that the things that we would expect to be delivered, such as toothbrushing, are not being uniformly delivered. In fact, they were quite low. Only about a third of patients were receiving those at baseline, which is important for the concepts that we're addressing in terms of biofilm and its eradication. And so it's really important to have that mechanical action. Also, we found out the staff were never trained in oral care delivery by oral health professionals. So they lacked skill and confidence in proceeding, and these things were often deprioritized in that setting, in part because of their skill set and their lack of value for it.
A couple questions have come in. Are there practical lessons from your trial on the de-adoption? That is, stopping doing low-value care in the ICU.
Well, Brian, I don't know if you want to take that one.
This is not. Are you struggling to hear me, Howard? I've been having sound problems.
It's good now. It's fine, Brian.
This is a superiority trial, so we have failed to show superiority. It's not a non-inferiority trial, but it's fair to say that this does not give any supporting evidence in mortality or IVACs, which correlate with VAP. And therefore, I think the replace from this result specifically state that we should withdraw this from practice.
Another question. Another question. Let's see. If this study was added to the meta-analysis that you quoted, would the results of that meta-analysis change?
Yeah, well, we've not done that, and the odds ratio for excess mortality and the confidence interval didn't overlap one in the previous meta-analyses. This is by far the biggest trial on this, and would probably move it to be a non-significant increase in mortality, but that work hasn't formally been done.
And then the last question, and then I'll turn it back to Joseph to close the session. How was IVAC calculated? Were you surprised IVAC was higher in the intervention group?
IVACs were calculated through our biostatistician through traditional means, which are common to international measures. We were surprised, and we have some theories about why IVACs might be slightly higher, including differences in the population in the intervention period, which included greater numbers of trauma patients.
Okay. Joseph, I'll turn it over to you for your closing remarks. And again, thank you so much for the last 3 years.
Thank you, Howard. We have listened to very exciting presentations, almost 3 hours long, providing us very important information. And Howard, I also thank you very much for sharing with me, but also for your nice words. And we are looking forward for many, many years in front of us for this collaboration. I'm not only closing actually the session, but almost closing this Congress, the whole Congress, which was a very special experience. Thanks to the Division of Scientific Affairs, the chair and the members, the office, and especially the faculty which participated here, and also to the participants who made the Congress a very interactive one. I would like now to ask for our president, Maurizio Cecconi, to join us in order to make the closing remarks. And I thank you very much to everybody who has been playing a role during these 4 days. Sorry.
I would have never imagined to become a president during a digital conference. However, the success of Lives 2020 Digital ensures me how connected our intensive care community is. And my message as a new president is a message of hope. I hope that with the help of citizens and with vaccinations, we will finally win the battle against COVID-19. I cannot be certain of it. But I am certain that our society is strong, thanks to the members, thanks to you, thanks to all of us in ESICM. And I know that we will carry on being a leading light for the community of intensive care medicine around the world. We will foster education, research. We will help to be better prepared against healthcare challenges in the future. This year has also shown what intensive care units are to the outside world, to lay people. It will be my priority to welcome these people into our intensive care unit, even when COVID will be finished. And we will carry on doing so also by opening our intensive care and showing to our patients and to our families that indeed we are here for them now, and we will be there for them, because we are intensive care.
As this year's Congress draws to a close, I would like to end with a few words of thanks to all our speakers, guests, participants, industry sponsors, exhibitors, Congress committee members, and the production team, and European Society of Intensive Care Medicine staff, who collectively have brought us such an invigorating program and Congress experience. I think you can agree that this has been a most informative and stimulating 3 days. We should all be able to take what we have learned and discussed back with us to our daily practice and to pass on any new information and knowledge to our teams and ultimately the patients in our care. This is what intensive care professionals do on a daily basis, and as we go forward, we are continually learning, expanding our knowledge, and improving our levels of care. Goodbye, and good luck, and thank you for joining Lives Digital 2020.
This year's Congress has left me with many impressions and ideas to take back to my intensive care units and also at the bedside. Personally, I really feel invigorated and stimulated, and I hope you have the same feeling. But Lives is not our only event. ESICM has a wealth of other educational events and many in store for next year, including e-masterclasses, forums and webinars. And the best thing what you can do is to be informed is look at our website. You probably wonder already what we have in mind for next year, for the next year annual Congress. And I can tell you that we have already begun to work on it, and we have some exciting plans and ideas. We will take with us some of the ideas of this year. I will now leave you with a short but exciting taste of what you can expect next year, Lives 2021 in Copenhagen. I thank you very much for being here with us, and see you next year, and keep safe and keep in good health.
system that we use.